minute. I just want to say hi to the Zoom audience. You are on our minds and in our hearts, even though you're there and we're here, we're all together. Okay, Jonah, hit the road. So while they're leaving, I just want to talk a little bit about the day. I worked with our amazing Summit Steering Committee to build the agenda, and we really wanted to take everybody through the CMT journey. So it's really important that we are supporting both pillars of the mission. So our next guest speaker, who is amazing, is going to talk about that diagnostic journey. And then once you have gone through that diagnostic journey, it's so important to learn about managing CMT. So if your neurologist says to you, you have CMT, there's nothing I can do for you, and shrugs their shoulder and sends you on their way, please find another neurologist, because you want someone who is going to talk to you about bracing, exercise, physical therapy, and how you're taking care of your body. There might be surgical interventions. So through the morning, we're going to be talking about that diagnostic journey and managing CMT. And then John already mentioned the very important breaks and lunch. And then in the afternoon, we're going to be talking about the research. And the CMTA is the largest philanthropic funder of CMTA research. And we could not do that without community and building community programs to support the research and the pathway to a cure. So I'm honored to introduce our next guest. I am hopefully saying his name correctly, Dr. Reza Saeed Sajadi, and he kindly lets us call him Dr. Reza. So Dr. Reza is the clinical director for the CMT Center of Excellence at Mass General and leads an amazing multidisciplinary clinic. So his team members are here as well. So I will turn it over to Dr. Reza. Thank you.
Morning. Thank you for the kind introduction, and thank you for having me here. It's an honor, and I'm really humbled to give the introduction to the community that knows more about the disease than most of neurologists. So it's a difficult task. It's a beautiful talks this morning. So I don't know how I can move the slides, or should I? Oh. Should I give you a signal to change, or?
Oh, where is it? Sorry. Yeah, we did not rehearse this, so.
I'm very well prepared.
Is it on here? Say hot or cold. Here?
No, it was with the last one.
Oh, Victoria.
Oh, that's okay.
She's right outside. That's it. Victoria, we need the clicker. Thank you. I'm getting all my steps in.
Now I have to learn how to operate this, but so thank you again. So we are part of, honored to be part of the CMTA Centers of Excellence that bring us a lot of resources that patients throughout the country can have access to: clinical care and multidisciplinary care, and neurologists who are more familiar with the condition, and the colleagues who can help. And we are also part of the Inherited Neuropathy Consortium led by Dr. Shai, bring out all clinical and research resources together and facilitating future collaborative research globally. So CMTs, or hereditary neuropathies in general, are a group of peripheral nervous system disorders that manifest with different disease severity. Patients may have very mild weakness to more significant disability, leading to difficulty with ambulation using upper extremities. Typically, patients are referred to as having distinct foot morphology and atrophy of the muscles in the leg and arm, and also distinctive pattern of gait in mild, moderate to severe, especially range of disease severity with foot drop, ataxic gait, and risk of fall. Not everybody is diagnosed early on. Most patients present with some delay in their milestones and early onset of distinct foot morphology and muscle atrophy. Some patients actually may have disease onset later. After age 40, they may have their first symptoms. So we call them as late onset CMT. So not everybody has the same disease course and diagnostic journey. Conventionally, CMTs are divided into what we call as CMT type 1 and type 2 based on their neurophysiology, which part of the peripheral nervous system was affected, whether it was an axonal process, part of the peripheral nerve was affected versus the demyelinating type where you have myelin sheath affected in the peripheral nervous system. And we had type 4s and type 1 and 2, again, divided based on the pattern of genetics, whether it was an autosomal dominant versus autosomal recessive. We heard this morning that the patients who are presented here in person and through Zoom, they about 50 to 60% of them have CMT type 1A, which is due to duplication of PMP22, followed by other subtypes of the disease. And we also know that roughly about half of patients who present with a clinical course consistent with CMT, they do not have a confirmed genetic diagnosis, or we have not been able to identify the real genetic cause of the disease. And there are multiple explanations why that would be the case, and that is one of the things that Inherited Neuropathy Consortium studies are looking into answering. So what patients go through is typically and conventionally into three major categories. The mainstay of diagnosis is clinical evaluation and history. The family history, the course, the history of progressive weakness or having balance issues, developmental changes, ankle foot instability, and over time development of Pescavis, distinct foot morphology and atrophy in the muscles and gait abnormalities. Now, also we conventionally relied on and still rely a lot on electrodiagnostics, EMG and nerve conduction studies, which are minimally uncomfortable tests, but they can help with the characterization of the underlying process and help us understand, one, if the problem is in fact peripheral nerve problem or versus a muscle problem, and whether there are hints that this is a hereditary condition versus something acquired, which may need a treatment, and also help direct the type of other tests that we can do. And finally, genetics, which we'll talk a little bit more about. So nerve conduction studies are, I put this slide and I'm assuming that most patients here have been through the testing, but it is not an ideal test, but it's not as uncomfortable as some people think it is. We practice on ourselves all the time, but it is mostly helpful characterizing the type of neuropathy we have, and also help us with finding differential diagnosis for acquired neuropathies, and also distinguishing some rare types of muscle diseases can present with similar manifestations. Now, with genetic testing, the question always comes is that whether you need to actually do electrodiagnostic testing. And at times, actually, if you have very severe neuropathy, or sometimes it's not feasible to do the genetic electrodiagnostic testing, we do the genetic testing earlier. Sometimes it's easier to do genetic testing and more cost-effective than doing electrophysiology. That's not always the case. And with dozens of options in terms of targeted testing and panels, it's now easier to do these. But the question comes is that why do I need to know my type? So first, it can sometimes help us with knowing what's the disease course, how we know about the other types of neuropathies, or people with the same type of neuropathy, what would happen. There are certain mutations in genes that they can have other manifestations beyond peripheral nervous system, and if we know that, that will be helpful. It would be helpful with regards to knowing whether you have a certain diagnosis and condition. For instance, times comes up whether you have an acquired neuropathy, such as chronic inflammatory demyelinating neuropathy, and if you have a final or a genetic diagnosis, that would prohibit you from having unnecessary testing, biopsies or CSF studies, or even unnecessary treatment. It can be helpful with family planning. So if you know that you have an autosomal recessive condition versus an autosomal dominant condition, and what are the chances and risks, and in terms of planning for family, and also genetic counseling, which Tricia will kindly talk more about later today. And we will talk hopefully in future about treatment and options, and most importantly, research with the evolution of new treatments and therapeutics that will come over the next few years. If you know what type you have, if there is a treatment option, obviously you would be eligible to participate hopefully in the studies. So the genetic testing we currently go after is the targeted sequencing. We do like the panels of genes, of more than 100 genes that we know about. There have been found some stronger association with some genes that have been described, and some are less well defined. But the targeted testing comes back with three different possibilities. One, you get results that is positive and it fits with the clinical presentation that you have confirmed with your clinical course and also the EMG, and they all match. So you have a confirmed diagnosis, that about the 50%. The other group is that the test comes back negative. And the question is that whether you can do a little bit more testing or more advanced testing, whole exome sequencing and whole genome sequencing, which again, Tricia will allude to. And by increasing the yield of diagnosis, it's possible that you can find some answers that you couldn't find with the targeted testing, though the margin is very small. Then the other problem that comes is the variance of unknown significance or inconclusiveness of the test. Sometimes you get results that they don't actually match with the clinical scenario, or the mutation that has been found is not necessarily explaining doesn't match with the patient, and or it doesn't actually explain if the mutation can cause the disease. In which case it would be helpful to do testing of the family members who are affected and unaffected, and occasionally we had the opportunity to do functional studies for some of the mutations to find out if they actually can be disease-causing or not. I think I skipped a slide, or I missed one, sorry. So about more comprehensive testing, always questions is it really going to change the management if we find out that you have a rare type of condition? And the answer is it depends. And that's why it would be very important to have access to a good genetic counselor like Tricia, who can really go through the pros and cons of more advanced testing. So usually the pros are that, again, similar to what we discussed earlier about the genetic counseling, family planning, avoiding unnecessary testing, and also research. But still, you may have no answer despite going through cost if it is something that is not done based on research. And also the question of other findings and unwanted information. You find out that you have a gene or a mutation that is not something that you were expecting, and now its implications, psychosocial implications of that, and also its impact on insurance. So these are all very important questions that also should be addressed by a genetic counselor. So what do we do at this stage? We go after how we can optimize patients' function and also slow complications as a result of the disease progression. So the mainstay of this are three things in my simple way of thinking. Our physical therapy, which in a sense we are working on mostly on core strengthening and balance training, stretch exercises, and we will talk about other strategies about how to improve function in the upper extremity and the lower extremity to prevent injuries and accidents. ankle foot orthotics, Ken kindly will present about different types of this. We have different types of braces that are conventional and more recent trends. And it's important to know that each patient is different in terms of the type of weakness and sensory changes that they have. And this bracing should be tailored to each and individual patient needs with regards to the degree of weakness, type of weakness, and its impact on their function. So I like this video from Ken again. If I can play both of them at the same time, I don't know. Oh, yes. So you can see the typical gait and imbalance in a patient, and you see how nicely it can be corrected in an earlier stage of disease, and that would prevent further damage to the bones and some of the structures that causing arthropathy and other complications of the disease. More importantly, reducing the risk of fall in patients who fall in that category of the impairment in the gait and function. And lastly, it's just about surgical interventions. This is a difficult question to answer. There has been some consensus published by some of our colleagues, and Dr. Herman also was part of this consensus statement. There are some options for the upper extremity and lower extremity function, and we used to be more liberal decades ago with surgical options, or they used to be operating on doing a lot of ankle fusion surgeries very early on in the course of disease. That's not the case usually, as some of these can be corrected with proper bracing and physical therapy. So surgical options should be weighed in terms of their potential benefits and risks, and it should be individually tailored, and it will be very, very important to have access to centers where they have experienced surgeons, especially in the pediatric population. So I think that I briefly mentioned the overall journey of the diagnostic journey, but I think this will continue with the talks from my colleagues about the management of the symptoms and bracing and genetic testing. Thank you.
John said in his opening speech that we were doing index cards, and that's not true. We just like to throw him off because he was an interim CEO and we wanted to see what he was made of. So we are actually going to do questions around the room for just one or two questions. We are not able, Dr. Reza and I are not able to answer personal medical questions. Just kidding, Dr. Reza. So no personal medical questions, but if you have a general neurology question for Dr. Reza, you can raise your hand and I'm going to come to you. And we have time for a couple. If we don't get to you, please email me your question and we will work on it.
Good morning, Dr. Reza. Thank you for your presentation. It's very informative. You mentioned in the genetic testing the variants of unknown significance, and through our journey, we've seen that there's continuous advancement in the diagnosis and the assignment of these of the variances that are of unknown significance. How does one, or how can one stay on top of this and be more aware of more recent findings? For example, in our son's case, one of the markers was very recently discovered. Do you have any clues or any hints on that, please?
I think that also that highlights the importance of the work that Dr. Schreis leads in the Inherited Neuropathy Consortium in regards to having a consolidated research database of what we have for a variant browser that we have that has like up-to-date information about different variants that are found in different genetic testing and the more genetic studies. It is very individual for the variants of unknown significance. So each variant would be different depending on the gene that you find and also where it is and what sources, what types of disease it would cause. So I think the fact that if we know that all the variants and the clinical correlation with them, that would enhance our ability to be able to say if a variant is more likely to be pathogenic or not, what's its relevance. And I think the more patients we have involved in research, I think it would help answer those questions more quickly.
Thank you.
Hello, thank you. I would like to ask about the CMT3 because I hear everybody talking about type 1, type 2, and type 4, but what about the 3 types?
Right. Well, type 3 used to refer to different types of CMT with different types of severity, but as over the past 2 or 3 decades, the genetics of neuropathies are a little bit more clarified, and we know that the specific genes are associated with the different types of CMT. We have learned that some conditions that we categorize under CMT, different names, now they belong to essentially the same genetic group. So most of them are dissolved, I would say, in the type 1 and type 2 and type 4.
Thank you.
Hello, Dr. Reza. How are you?
Hi, great. Thank you.
So I would like to ask a question about family history. So I've been reading a lot. My father passed away just a couple of years ago with this disease, and I actually found it, and he'd been looking for it for 35, 40 years. He didn't get any answers, but I finally did after 24 years. So I've been trying to figure out how it falls in the family history. I heard and read that maybe 50% of the children may get it. So only if there's 2 siblings, only one will and one would. How do I look more into the family history to find out where it came from?
Yeah, it's a great question. And I think, again, I would defer, just like many more difficult questions, to my colleague, Tricia, who will talk more about this. But when we say it's an autosomal dominant condition, it means that you just need one gene to cause the disease. And that means that there's a 50% chance of passing the gene. Now, that 50% is 50% for each child. Doesn't mean that if one child has it, the other child will not have it. That's one thing. The second thing is that not all types of CMTs are autosomal dominant, and even autosomal dominant CMTs, not all of them are inherited. Depending on the type of CMT, sometimes you can have what we call as a de novo mutation, meaning that parents did not have it, but this mutation happened in the individual. Lastly, it's also important to know that different types of CMT would have different, what they call as a variable penetrance. Some types of CMT would have mild manifestations in one sibling and more severe manifestations in the other siblings. And sometimes some types of CMTs, one mutation can present itself as fulminant type of CMT, and the other patient may be asymptomatic or mildly symptomatic. A good example of that is CMT type X1 or 1X, when female carriers may have very minimal symptoms, or some of them may have more symptoms or none, and male family members may have more severe disease. So it depends on the individual gene. So that's why I would defer to Tricia.
Thank you. Any other questions from the audience? Okay. Are you?
Elaborate on the risks of surgery. I've heard a lot of people talk about the benefits, but what are some of the major risks?
So there's a common saying among surgeons, is that, especially ophthalmologists, that they usually say that there is no surgery that does not have side effects. So surgery can go wrong. Surgery is an art, in my opinion, and also depends on who does it. They can fix a lot of things, but they can break a lot of things. The other problem with surgery is that if you have a condition which is a progressive condition, if you do the surgery, you cannot predict what will happen in future as you evolve or the disease progresses. Does that guarantee that you will not have a surgery? And is it going to actually, at this stage that where you are, fix all the needs for what is being fixed or what we are trying to fix? Is it going to fix the weakness? Probably not. Is it going to fix the lack of sensory response or loss of sensation. It is not. So it is not going to make you independent in general from the other things that you need to improve your quality of life, including bracing or physical therapy or other function. Sometimes it's absolutely needed because the foot deformity is such that it cannot be reduced by any other measure and you have a lot of pain. So you need to have some sort of a relief to be able to do those things. But I think there are different approaches, and obviously, most importantly, I think, is that depends on the surgeon. So I think it would be very important to weigh risks and benefits and also identify a person who's good at what they do.
Any other questions? I see a hand in the back. Okay, I'm going to come down the side. Or if you're loud like that guy.
Thank you.
Thanks, sir.
What are your thoughts on CRISPR for a potential for helping with CMT or?
So that's a great question, and I don't have a good answer for you. So I think that's a question for the afternoon session. If that's but there are very exciting things about different mechanisms in different genes, and in general, we're all excited about the potentials. But it depends on the specific scenario and where we are with other options versus CRISPR and other things. So I think I would like to talk more specifically if that's, or we can talk in the afternoon sessions about this.
That's an excellent question. And Dr. Bruce Conklin will be talking about CRISPR, and several other of our scientists will be talking about gene therapy options for CMT. Yes.
Yes. What's the impact of alcohol on the progression of the disease? In other words, I know, yes, if I have 3 glasses of wine, I get more unstable without CMT. So, so I do recognize that. But my daughter asked me the other night about that. So.
Might have more fun, though.
That's also an excellent question. Not only alcohol, but a lot of other conditions that we know. Neuropathy is actually quite common, believe it or not. It's in the general population. And alcohol is known, one of the known causes of peripheral neuropathy. Also similar to diabetes, that we know that it can have an impact on neuropathy. So patients with CMTs, different types of CMTs are obviously different, but they already have a neuropathy. And in addition to that, if they develop a secondary neuropathy, especially, let's say, associated with diabetes or alcohol, and that would be, that could affect their gait and balance even more. Alcohol can also affect the cerebellar system and cause more difficulty with the balance, in addition to the peripheral nervous system. So it's always this similar precautions in its general population. It's advised to sort of take everything in moderation.
Thank you. We are now going to go to the Zoom chat room. We have not forgotten about you lovely folks on Zoom. If you want to ask the first question.
Yes, one of the questions was, my son has ankylosing spondylitis and wanted to know if that was related at all to CMT.
So that's a rheumatological condition. The question is that whether that diagnosis is made based on the rheumatological workup or is a clinical diagnosis. For sure, if somebody has ankylosing spondylitis, there's a possibility that their gait and their function will be more limited compared to somebody who just has CMT. But it will be difficult to say without seeing the patient. But I think it can concurrently it can affect patients more. But CMT, to my knowledge, does not cause ankylosing spondylitis.
Thank you.
Thank you. The next question was if it was possible to have more than one type of CMT.
Interestingly, yes. So it's not super common, but it is possible that you can have more than one type of mutation. I have few patients who are like that. And it is more common to actually have a mutation that is causing the disease and a variant of unknown significance. So you have to be careful about those findings in genetic testing. But there are patients who have two different types of mutations that can cause two patients with Noonan syndrome and CMT. They would have slightly more severe manifestations of disease and some other hereditary conditions as well.
Thank you. And then the last question was if it was typically accurate, the earlier the age of diagnosis, if there's a correlation between that and the severity of the outcome.
Well, not necessarily. It all depends on the type of CMT and how disease progresses over time. Some consideration in pediatric patient population that I have seen is that the clinical course in adults, we always talk about the progressive course, and in more severe cases, that's usually the case. But in pediatric cases, when they present, especially in early years, sometimes actually disease can progress slower than the child growth. So it is possible that you can have some fluctuation in the degree of weakness, and sometimes even you can get better and slower and faster at times. So it would be difficult to determine the course, I would say, accurately when you are very young. So time usually will tell. And usually I would say when you're in teens, you start to be able to say if the disease is or what's the projection of the disease progression. And this is just my experience.
Thank you. I'm sorry, we have one more question in the chat wondering, actually, there's a lot of people asking this question. If you know what the braces were that the patient was wearing in the video that you shared.
Come again?
They wanted to know if you knew what type of braces the person was wearing in the video.
Oh, in the video, yes. So again, I'll defer to Ken. He will give us a beautiful talk about the braces. I think if I'm not wrong, this was like the type of braces that they use usually help with the anticipatory gait function. So they help with the center of gravity, and they help with the balance. So I'll let Ken talk more about the specifics of that specific case too. But it's a type of brace that helps you not only clear your foot, but also help you propel your center of gravity forward. And with some physical therapy, it would be possible to have a better balance and gait.
Wonderful. Thank you. And we do have an entire session dedicated to bracing. I want to thank Dr. Reza for being with us today and for the wonderful presentation. If you are in the Help for Today panel with Dr. Kathy Chuang, please make your way to the front. I am going to come up here and leave the mic.